Welcome back to our series on acute pancreatitis.
Do again.
Now, I need your help to manage this patient, and I promise you that by the end of the video, we'll be able to manage any patient that presents in the ER with these symptoms. Alright, picture yourself as a superhero on a mission. You have two goals. First, to make the patient able to stand on the feet, i.e., make the patient comfortable by managing the pain, vomiting, nausea, and second, you have to prevent any complications, i.e., the end organ damage, including the kidneys, the lungs, and the heart. Let's break this superhero mission into 6 easy steps, like assembling the ultimate team of Avengers to save the day. The Avenger 1 captain and PO has to make sure that the patient stops eating or drinking anything. This is all about giving the pancreas a much needed break. This not only reduces the workload on the pancreas but also prevents the production of more enzyme that could potentially lead to further damage. Until then, we can provide nutrition by the antral or parenteral route, but the antral route is preferred over the parenteral route because when the bowel is at rest, there is translocation of the bacteria, which can cause infections. To prevent this, we need to keep the gut active. So, the solution or the formula that we give is high protein, low fat formulas like that of the Peptamen, ensuring she gets the fuel she needs to fight his way back to health. Alright, folks, time for a quiz. After some hours, patient said those magic words that she is hungry. But we ran the lipase and turns out they're still raised. So, should we give her the green signal to eat orally or not? Feeling hungry is a sign that digestive system is all set, ready to handle more food again. When we have to reintroduce food into the gut, we start with easy to digest foods like fluids, water, clear broths, soups, ORS. They do the work. But we gradually shift towards the solid foods like boiled vegetables. Try to choose low fat, low residue diet. And if the symptoms of the patients are severe, like severe vomiting, nausea, pain, or she has severe pancreatitis, then continue NPO for 4 to 5 days and then again wait for her to feel hungry. The next Avenger, aka Hydration Hulk, steps in for the fluid resuscitation. We know that the pancreas are burning and we have to throw some water on the burning pancreas. So the hydration hulk ensures that the patient gets the right amount of fluids. Be honest, that's the only effective treatment that we can give in the first 2 days. The Avenger 2 is analyzing the options. We have the dextrose water saline, which would give energy boost. We have normal saline, which would replenish the fluids and electrolytes. And we have Ringer's lactate, which has a role in pH balancing, which has an ideal electrolyte composition, and has a role in maintaining tissue perfusion, which makes it an ideal fluid for fluid resuscitation and hydration. So, Hulk's hand reaches for Ringer's lactate, which he gave 1.5 ml per kilogram per hour. And if the patient is in hypovolemia, then we can give 10 ml per kilogram bolus at once. But you know what? His job is not done yet. He has got a big responsibility. He cannot just sit there and play video games. He has to monitor his patient every now and then. He has to check for any edema in the feet or in the lungs of the patient, like he has to auscultate the chest. Then he has to maintain the vitals, in which he has to keep the heart rate less than 120 beat per minute. He has to check the blood pressure every now and then, and he has to monitor the urine output, which should be not more than zero point 0.5 to 1 cubic centimeter per kilogram per hour. On top of that, he has to check the BUN level. He has to run BUN blood test because it's a good prognostic indicator to detect the hydration status of the patient. So, if BUN levels are not improving, he has got a problem, and then he has to reassess the hydration status, increase the fluid rate, assess the kidney functions, and monitor for any complications. So keep in mind that rehydration is a critical and absolutely essential step in managing the patient with acute pancreatitis. Next up, we have the Avenger 3, the pain management man, swooping in to tackle
My
Sarah's
stomach is
pain.
killing me. Please, I need something for this pain right away.
But the pain management man has to think carefully before giving any painkiller. He has to decide between NSAID and opioid. You know, he can give NSAIDs if the BUN and RFTs are normal, i.e., the kidneys are not damaged. But if the kidneys are damaged, then opioids would be safe. And he can give hydroxymorphine, IV fentanyl, or meperidine. But you know what? The morphine is not a good thing to give in this case before morphine constricts the sphincter of Oddi, which will further worsen the case. This chart is made by the pain management man to show that strategy he would follow to manage the pain, and the last option is non-opioid analgesics. Now the Avenger 4, the nausea neutralizer, steps in with the antiemetics to stabilize the nausea and vomiting of the patient. And the nausea neutralizer probably remembers the dancing girl from the sketchy pharma, so he decides to give ondansetron 4 to 8 milligrams IV to settle the nausea and vomiting of the patient. Not always the main hero in this battle is the antibiotic avenger, and we have to discuss whether to give antibiotics in this case or not. Because there are only certain conditions in which we would give antibiotics, which include when there is any necrotic material or there is any infective necrotic material or the score of the patient is bad or we have proven bacteremia or cholangitis. And keep in mind that we never give antibiotic prophylactically in acute pancreatitis. And our patient has mild interstitial pancreatitis, so we would not give any antibiotics. And finally, we have the Avenger 6, the Blade Master, standing for surgical intervention. The Blade Master is required when there is biliary pancreatitis. I won't go in details, but the things I would like to mention here are that if the patient has cholangitis and it's confirmed, then we have to do an urgent therapeutic ERCP on the same day, i.e., within 24 hours. If the patient has mild acute pancreatitis, we have to remove the gallbladder in the same admission. And if there is moderate severe pancreatitis or fluid collection, then we can delay the surgery till it's resolved. If the blade master sees a pseudocyst on a CT scan and it is asymptomatic, then he will wait and watch because he believes that it will resolve on its own. And he repeats the imaging again after 6 weeks to check if it's still there or not. And if it is still there or the patient becomes symptomatic, then he would drain the cyst or the necrotic abscess. He would drain it. And there are numerous options available for him, like radiology, surgical, endoscopic, or transpapillary transductal drainage. So he would opt one according to this algorithm. Here's a summary of everything we have learned today, and I hope that now if you come across with a patient, you would treat him. Until now, I have focused on the fundamentals that are must in the management, but other steps are specific and are needed in specific conditions, so you can read them. I hope to see you in the next video.